Hi, I'm Dr. Lyons from Lyons Family Dentistry. We are producing a video, which will be like a home video. Don't look into this as a serious thing, but I want to help any new employees who are not familiar with the dental industry. Don't be afraid. It's a lot of new names, a lot of new concepts, but I will help you to break it into simple elements, and it should help you. The dental field is very exciting, and when you overcome these obstacles of knowing the names and procedures, it will be easy navigation. So let's start from the beginning. So adult person, we have adult teeth or pediatric teeth. So adult people, they have usually 28 teeth plus 4 teeth of the wisdom teeth, so it's 32. But if some people don't have a wisdom teeth, some people have more of it. I had a patient who had 8 wisdom teeth, so it could be anomalies. Pediatric, they have 20 teeth, so it's the children around age 6, 8. They start losing the baby's teeth and adult teeth are growing, but they have 20 teeth. To count the teeth, for adult people, you will use international system, meaning counting teeth from 1 to 16, from right upper to right left, and then you're going to drop down from lower left, from number 17 to number 32 on the lower right. So this is how we number the teeth. So if you have any procedure done on any tooth, you will say tooth number 5 or tooth number 6, and we will correspond with a number in a jaw. So for a baby's teeth, we use different system. It's alphabetic, and it's from A to T. And again, from A, B, C, D, and ends up on a T. Okay, so that's initial. What do we have? What kind of a teeth? To do exam, in order to do exam on a patient, we have to have x-rays, we have to have intraoral pictures, we have to have periodontal charting, and you have to have an oral cancer screening. I know it seems like difficult, but it's not. Let's go from the beginning. So panoramic picture. Panoramic, just think about it like if you take pictures when you're having vacation and you take a panoramic pictures. It shows more, it gives you better, bigger field. So on a panoramic pictures, you will be able to see eye sockets, sinuses, teeth, impacted teeth, teeth which grow, you cannot see in the mouth, but they are actually in the bone. So this is a panoramic film. The panoramic film gives you like a good idea about your TMJ, give you a good idea about, bone accessibility and how much bone we have for implants or something. So it's kind of like a general, big picture. If somebody is congenitally missing some teeth, we will see that too, because on the panoramic picture, for a child 6 years old, he should have at least already buds for adult teeth. If they don't have it, they genetically will be missing this teeth. So it's good. It's a good screening for possible future problems. So this is a panoramic film. Then we have individual films. Individual films like we call this PA for short, but it calls periapical picture. Periapical picture is when you see the crown and the root of the tooth. So that's important in diagnosis any, let's say, for root canal, any infection on the tip of a root. So this is PA will be like, for administrative portion, like if you have to submit it PA and a bite wing, then you will know what kind of a picture to attach to your claim. Bite wing shows only crown, and it shows the crown of a tooth with a neighboring teeth. And that is very important to diagnose any cavities between the teeth. So if we have an emergency, we always take a PA and a bite wing. So that's what you need to know about this x-rays. So we got x-rays, panoramic, PA, and a bite wing. That's what you will be operating. So to complete full exam, usually on the new patients, we take a panoramic pictures and it calls FMX. FMX is a full mouth series, and a full mouth series will consist of the several PA, periapicals, and several bite wings, and that gives us a radiographic examination of a patient. But in order to assess them fully, we also use intraoral camera, and we do with intraoral camera, we capture the pictures of the teeth, and we will have to show you this. But patients don't always understand, like, x-rays, how they look and this, but on the intraoral pictures, you can show them a crack, a defective filling, broken, and sometimes they look and they just cannot believe it, that it's really happening. But it's a very useful tool for a patient. So we got x-rays, we got intraoral pictures, then we use oral cancer screening. We use the tool called Velscope, and what it does, we turn the lights off and we do oral examination with a Velscope. It does illuminate the area. It does not show you cancer, but what it does, potential spot problems, it will illuminate and it will show like a dark spot in the mouth. Then it alerts us to, like, we push on it. If it's blanching nicely, that's mean it's just broken vessel, very superficial. But if we push on a dark spot and it doesn't blanch, it's deeper. And if it's deeper, we have to look more into it and possibly sending for a biopsy. So we got x-rays, we got intraoral pictures, we got oral cancer screening, and then is another exam of evaluating the gum of a patient, and that calls periodontal charting. Periodontal charting will be done by a hygienist, and she will use the perio probe, which is marked with the distances like 1 millimeter, 3 millimeters, 5 millimeters, 7 and plus 10. So what a hygienist does, she put this explorer, that perio probe, between the tooth and the gum and see how deep it sinks. If the readings is between 0 to 3, they are healthy gums. Anything 4 and more shows the inflammation. Some are like, even if you get to 10 millimeters, it's a very advanced periodontal disease. So on the base of this, of a periodontal charting, we come up with a treatment for a patient. It could be regular prophy, it could be debridement, like if somebody has a lot of calculus, a lot of cover, and we can show you pictures of that. If they have a lot of that, then you cannot even assess like the pocket, so you have to clean it first. It's like a gross debridement. And then we bring the patient again to evaluate the gums. So if they need the pockets are deep and they need periodontal treatment, it's different. It will be scaling root planing, it calls, because we got to treat the root. We have to numb the patient. We have to go deep with instruments and remove any debris. So that you will need for administrative purpose. A lot of times when you send a claim for scaling root planing, you need to know if you're sending for 1 quadrant, for 2 quadrants, and you have to send a periodontal charting, which is very important. So now we have x-rays, we have intraoral, we have oral cancer screening, and we have a gum assessment. That's a full examination. And in order to do that, we do comprehensive, this will conclude it. These are the elements of a comprehensive oral exam. We do this on a new patient or a patient who's returning after a long time, like let's say that they didn't have it in 3 years, then we do comprehensive. Other exams could be just periodic, or it could be a limited exam if somebody comes in pain and we take a couple pictures just to assess them for what it is. Or so periodic or limited, they will have a different codes, but the providers will give you the codes and name what was done. Okay, that will complete the initial assessment of a patient. So the question comes in, like patient will call you and say from what age you should bring your children, and all different practices are doing different things. I understand there's some dentists, they bring the babies where they don't even have a teeth and sell them some gauzes to clean up the plaque. The plaque does formulate on the gums even if the child doesn't have a teeth. Every 24 hours you have a buildup of a plaque. So it's, we bring the child no younger than like 3 years old. A lot of times it's really nice when a patient brings the child with them on their exam when they are young, so they get used to it. It doesn't mean we do exam, but we just let them explore like a dental operatory. We let them use the water syringe, show the gloves, make the balloon out of a glove, so they get used to the chair, the light, the sunglasses, the pictures and all that. So a lot of times, like a first appointment, they're actually not a dental appointment, but we want a child will like the environment and want it to come. But when we start seeing pediatric patients, usually what they have problems will be, lately, actually, a lot of kids, they have a wonderful teeth. The parents are taking great care of that. The kids, not too many kids really have cavities. That's because of a fluoride, because of a great home care. So, parents are taking really good care of the children. It happens seldom when we have children who need like extensive work. Most of the time, the children will just need the sealants on an adult healthy teeth. So the tooth has like on the coronal part, on the top of a tooth, there's a lot of grooves, just like on the hand you have grooves. And these grooves are the most vulnerable to become a cavity in it because they are not totally fused completely. So if you introduce sugar, and that sugar is introduced for about 20 minutes, that is enough, that sugar, to be converting to bacteria on it to acid, and it will start eroding in the tooth. It doesn't happen overnight. In order to get a cavity, actually, acidity in the mouth should be, the tooth should be exposed for about 2 years. But after 2 years, you're going to break enamel and you're going to start to have a cavity. Enamel is the hardest substance in our body, so it's not that easy to break it. But in 2 years you can, and if you break enamel, then under that is another layer which much softer, and that will lead to more problems, to deep cavities, root canals, or even extractions. So the sealants is like a preventive thing. You put on adult teeth in this groove, that vulnerable grooves. We put like it looks like a nail polish, honestly. You just paint in the grooves, and it protects this groove from not being attacked by acid. And that's a fantastic prevention, and because children, if they get the cavities, they get cavities on the top of the tooth first. The sealant will not prevent the cavity formulating between the teeth, but on the top of the tooth. But it's a standard thing for any adult teeth emerging, any back teeth. The back teeth, I didn't mention that before. The back teeth, we call them posterior, and the front teeth, we call them anterior. And it's like from a canine to canine, from your eye teeth, this is anterior range, and then the rest is the posterior back teeth. So any posterior teeth, which adult should have it like 4 in each quadrant, should be sealed in order to protect the child from having a cavity in this teeth. Okay. If it happens that the child loses the tooth, or we have to take the tooth out prematurely, your baby tooth, then we take the tooth out, but we also have to protect the space in order that other baby teeth will not drift into it, and protect the space for adult teeth from underneath to come in a correct way. So we call this space maintainer. So in an event like that, what we do, we take impression, we send it to lab, and they produce something like they call this space maintainer. and we cement that and we hold on to that until we see that adult tooth is coming, then we remove that. So it's just a protection of a space so that adult tooth can move. For administrative purpose, you will have, for example, so that calls space maintainer unilateral because it's only in one quadrant. But if the child is missing tooth on one side and the other side, then we call this bilateral. So you have a different code for unilateral space maintainer or bilateral space maintainer. Okay, so I think on the children, and if they need the fillings, we do the fillings, but, or any extensive other work. But basically, you will have to use for children mouth the teeth designated with the teeth, with the alphabetical naming of a teeth. The tooth A or B got extracted, and then the space maintainer will be in this record. So I think you just need that much for a pedo. So we have adult teeth. I think the most challenging for somebody from administrative, not the dental field, and understandably, is surfaces on a teeth. And they're called all differently, like a back teeth differently, front teeth differently. So we will go over some and I will give you examples, but you will be using, you will be using different nomenclature for that. And I think this is like really difficult, but we'll make it simple. So for example, if you break the main wall of a tooth, which is on the front of a tooth, we call this mesial. If it's on the back of a tooth, we call this distal. If it's some surfaces around the cheek, they call this buccal. If it's around the tongue, they call this lingual. So when you will see description like tooth number 19, MOD, that's mean mesial, occlusal, and a distal. That's mean free surface of a tooth were replaced with a filling. I give you tons of this examples so you can practice on that on a separate sheet. Anterior teeth will be called a little differently because they don't have occlusal, they have incisal edges. And like I said, it seems like difficult, but we give you like a little script on each surface with a description, so you should not have any problem with that. So if the filling is too deep and a cavity broke free enamel, it took about 2 years, but then it goes to dent into the other layer. That is a soft layer. 6 months in a dentin, and it ends it in a root canal. Now, what is a root canal? So the teeth, they do have a roots. And I have to tell you a funny thing. I had an administrative person who came in, and she had no idea the tooth has a roots. She didn't know anything about dentistry. And I tell you, after training, she was the best administrative person, and she is training people now how to do it. So if it sounds like elementary, just humor yourself and just watch it. But tooth has a roots, and each teeth, like anterior teeth, they usually have a 1 root, could have 2. Posterior teeth, they can have 2 roots, 3 roots, 4 roots. I even saw like some 5 roots. Now each root has a canals where the nerve goes, and sometimes they can have 2 canals in a 1 root, which gets very complicated. For that reason, when you do root canals, what we do, we remove the nerve from each canal. So like, for example, upper molars, they have 3 roots, but a lot of times they have 4 canals. They have 2 canals in 1 root. For that reason, root canals on a back teeth, on the molars, they take much longer, so you have to schedule longer time. For example, like on the front tooth, when you have a 1 canal, you can be done with a root canal in half an hour, depends on the provider. For the back tooth, you need to have additional time, at least 2 hours, because they are way more involved. But when we do root canal, we take the nerves out, we clean up, make sure you have no infection, and then we seal with a plastic, actually goes inside of a root. We do not remove the root. The roots still stay in your jaw, but we remove infection. So you will have, for administrative reason, you will have a root canal, different codes for anterior teeth and a different for posterior teeth. And it will be different prices attached to it. So after root canal, the tooth is devitalized, meaning the tooth is dead. It doesn't get any more nutrients, doesn't get the water, so it's very fragile. So you can fracture the tooth. So for that reason, it's mandatory to give some kind of foundation to the tooth buildup. And then on the top of the buildup, we put a crown. Again, for administrative reason, you're going to have two different codes for a buildup, because one buildup can be done right in the office. If it's enough structure of a tooth left, we can do, it calls direct buildup. We have a one code. Or indirect buildup, which is usually called cast, post, and core. Meaning we take impression of that, send it to the lab, and the lab fabricates out of a metal little cast, post, and core. It's like a miniature implant inside of your tooth. But that supports the whole structure of a tooth, and now you can put a crown on it. Just that. When you're missing teeth, you're going to have all different options. So, for example, again, I'm gearing this for administrative staff who doesn't know any dental. So, lower jaw, call this mandible. Upper jaw, call this maxilla. So, if somebody is missing teeth, and it's a lower jaw, so it's mandibular, and how are we going to restore? We have all kinds of options to restore, but let's say we go with the lowest possible like restoration. So to fill the gaps, we call this partial. And a partial, you will, like if you send to insurance, you have to say what kind of a partial you have. Do you have a mandibular or maxillary? And then you have to designate it which teeth are missing. And that clinical people will mark them, so you will know which are missing, which are not. And then you will send to insurance mandibular cast partial. Cast meaning it has the metal in it, and it was cast. So this is what, it's a different code. So that will be mandibular cast partial. If you don't have a metal, then we call this acrylic partial, and there will be no metal. It looks nicer, but not always very functional, because acrylic usually it has to be bigger in order to have a retention and then moving. Metal can be thinner, and it's also better structure if you have some other teeth who are not so great. It's easier to, if you lose them, add to existing partials. So you have acrylic partials, or you have a cast metal partials. And then you have to say which arch, lower, mandibular, upper, maxillary. If you missed all the teeth, then it calls denture, when you have no teeth. So it's a denture, it's like when you don't have any teeth. So again, you will have a code for a maxillary denture, which means upper without any teeth, and mandibular denture, which is lower arch without the teeth. A lot of times in our process, we will call immediate denture. What does it mean, immediate denture? Immediate denture, it's a different code again, but it happens when a patient has some teeth in it. We took preliminary impressions, we sent to the lab, and the lab is more or less guessing how it's supposed to be. They cut the teeth on the model, and they design the denture, and they send it to us. We get this denture when a patient still has a teeth in the mouth. And what we do during surgery, we extract the teeth, and then put the sutures, and then we put the denture prefabricated from a lab right away, same day. So it's actually works like a what do you call this? Like a cast, what do you call this? It keeps in mouth, like if you keep it right after surgery, you do not swell up. If you remove that, then it could swell up and you won't be able to put it back, like a cast. So then they call this immediate denture. We put immediate so they never walk without the teeth. We took the teeth out, we put right away some teeth. That immediate dentures we're going to be using for about 6 weeks. And at 6 weeks, it's a time for healing. and the denture is going to get looser. Then we use the relines until a good 6 weeks. When everything is healed, we will take a new impression and make them a final denture, which will fit to the heal process. So that first denture will be as like a temporary denture. But when we call this immediate, actually the patient will receive 2 dentures, the temporary one and then a final product. Different type of restoration in the mouth. So you can have a filling, then you can have a crown, you can have veneer, you can have a bridge, you can have an implant. But let's go over some. So what is the crown? Crown is, where is the crown? Here. When you don't have enough structure to support the tooth, like all the walls are defective because they had a fracture or they had a cavity and now you just build it up, then you have to support the tooth with the full coverage. So the full coverage, it calls crown. Some people call this cap. And again, you will have a specific code for porcelain crown, for gold crown. We do them occasionally for a PFM crown. PFM means porcelain fused to metal, which means it will be metal under that and the porcelain baked on it. Anymore, they're very, very seldom we do PFM because the new technology is so fantastic. Like the new crowns, they are beautiful. It's all porcelain. It doesn't have a metal. The light goes through. They look like a natural teeth. And they are very, very strong. So anymore, really, truly, like the old porcelain is used for crowns. So this is a crown. The crown is kind of like a helmet for the tooth. So now after root canal, you had to put it, or if you have not enough structure of a tooth, and if the patient needs the crown, administrative people, what you need to be looking forward if you're submitting the claim, you have to tell insurance if it's an initial placement or it's a replacement. Again, the provider has to help you with that. Doctor, they have to tell you it's an initial placement because not enough tooth structure or if it was a root canal. Initial. If it's a replacement, you need to know from a patient how old is this crown. Usually insurances, they cover them every 5 years. So let's say if patient doesn't remember, it's like I say 5 years or maybe longer, you just put 5+ years old. And why? Because it's defective, because it has an open margin, because they have a recurrent caries. That information, provider has to give it to you, but your role will be to attach the x-ray of that for claim and indicate if it's an initial or it's a replacement. So this is a crown. Bridges. A lot of older people, they call partial bridges. So you have to kind of watch it what they say when they say like, oh, my bridge is broken. You don't know if it's a bridge or really partial. So they come in and we clarify. So bridge is actually something fixed. So you're missing the tooth. And what you're going to do in order to do the bridge, you're going to reduce the one tooth on the front of it and one tooth behind that. And then you take impression, you send it to the lab, and you get like a free unit piece. Then comes back for a lab, you cement that, you cement this permanently. So this is where you're going to get in vocabulary again. This is fixed. So a bridge is fixed because you cement it and you can't take it out. From looking perspective, it's going to look very nice, but sometimes it's a challenge to clean under the bridge for a patient. But that will be under fixed restorative. Crown, bridge, it will be fixed because you fix it and you cannot remove it. Partials and dentures will be under removable. Different codes again. So you got a bridge. Got it. What is this one? Yeah, this is another bridge, another long bridge. So in a bridge, the teeth which support the bridge, the actual teeth, we call them abutment. An abutment is going to have a different code than a pontic. So the teeth which support the bridge, we call this abutment. And a teeth which is the empty space which is replaced with a tooth, it calls pontic. So pontic is the missing tooth, abutments is the supporting teeth of a bridge. Okay, we're going to go to restorative process of implants. So when you're going to have implants, what's the implant? Implant is we're going to replace your tooth, your missing tooth, and you're going to put the implant in it. So the first part of an implant will be to place the implant body, we call this body, it goes into the jaw, and you have a code for the implant placement. Sometimes you have to use the bone graft to support that implant, so you will have another code. It will be implant placement plus bone graft. After that, the implant has to integrate in the bone, about 3 to 4 months. And in order to know that it's integrated, we got to take x-rays, periapical, where you can see that the bone grows into this groove in the root. So this has to integrate in the bone. After, if it's integrated, we take impression, and we take impression for implant abutment. So see, this is different than a bridge abutment. This is implant abutment. Implant abutment is a structure which goes inside of an implant, and that gives you support for the crown on this implant. A lot of times it comes as a one unit, but it's actually two components. So administrative reason, you have the one code for the implant, one code for a bone graft, one code for abutment, and then one code for an implant crown. But they're all combined together, so you will know where to look for it. Sometimes we do have a bridge on the implants. So like you had a other, like I showed you the bridge where you have enough of your teeth to support the bridge. But if you don't, and the space is big, you can do the bridge on the implants. Again, it will be fixed in the implants. And again, you will have put codes for what an implant is, for implant code, and the bridge will be abutment for an implant bridge, pontic for an implant bridge, and abutment for an implant bridge. When we take the tooth out, and the patient is not going to have this implant restored for 3 to 4 months, if it's in a static zone, sometimes we can provide we call this flipper. It's a temporary thing we put in a missing tooth. It's acrylic, it's usually flexible. And what it does, it clips in, so the patient has a tooth. So aesthetically, you don't, it looks pretty good. But you have to be careful, because for eating or sleeping, you got to take it out. You could swallow that. You will have additional code for a flipper. So when somebody is doing implant, if it's in a static zone, clinical staff will tell you if we're going to have a flipper or not, and it's a different code, different fees for it. When we talk about the dentures relies on a bone level in the gum, on the lower and upper. Upper denture usually stays because of a suction. A palate is like concave. The more concave, the denture stays better. But you also have to cover the whole palate, and a lot of bad taste are on a palate. So you cannot taste the food if it's covered completely. So it takes away from eating experiences for a patient. But you can make an upper denture cutting the palate out. If somebody is a gagger, they cannot tolerate the big thing on the palate. So we can do denture on the top without palate. But in order to do that, we have to have some implants supporting denture. So usually on the upper, we want to have a minimum 4 implants, and on the lower, minimum 2 implants. How do they help these implants? They help extremely instability of a denture, because they call this overdenture, denture supported with the implants, it calls overdenture. So now when we send a treatment plan, and it will be, let's say, mandibular, denture, full denture. And then we're going to put implants. But also the implants, they're going to have like a little notches here. And these notches, they call them, what do I call them? locators. Here we go. See, even I forget this stuff. So on the implant, you put the locators, and it depends what size it is and all that. So let's say if we make the denture for administrative purpose, we did the denture with the implants. You will have a separate codes for denture, for implants, for locators. So locators is going to stay in a gum, stay on a bone. And then a denture has to have a partner for that. So they call housing. And this housing goes, the locators goes in a housing and it stays, and the denture doesn't move, and the patient can chew and cut and everything. Cut the food with this. So you will have the codes for implants, different, for locators, different, for a housing, different, for a denture, different. So it's a lot of different codes, but again, they are grouped together. So if you have a case like that, clinical stuff will help you, but I need you to understand what it is. What's a locator, what's a housing, where it is, okay? So housing is in appliance, locators is in a mouth, and you don't remove them. And housings, they come with a little gaskets for retention. Usually we start with the black ones, and then have a different retention. They have a different color, so if they get a little loose, then we change for a tighter one. That's actually a great treatment for a patient, because they have a, in a denture doesn't change that much in technology. Long time ago, the denture was just to look good, so people wear the teeth to church, and then they were eating without it. Now people want to look good, but also want to have a functionality. And in order to have functionality, we need to support these dentures with the implants. Okay, so one of my favorite subjects is cosmetic dentistry, and it's really wonderful. So like when we have a big cosmetic case, what we do, we take initial diagnostic study models, and then we maybe have to send to the laboratory for wax up. And it's a special fee, you will see the special code. And what they do the wax up for us. So they do on a model, they will cut the teeth in ideal position, and they will send us a temporary, which is very beautiful, and they send us the wax up. So it will be wax up teeth for a big cosmetic cases, and they will also produce for us very nice temporaries, and it looks great, and it helps us with the finishing stuff. So that's for cosmetic reason. Other thing for cosmetic reason is if you want to change occlusion for everybody. So if we want to change, we can use Invisalign. We use Invisalign in our office for orthodontic treatment. We scan the patients with iTero, so it's digital scanning, no googs in the mouth. And then we get these aligners, and it depends on the case. The aligners is like used by a patient usually between 1 week to 2 weeks, each aligner, and then you go for next one and next one. Each of these aligners, they have a built-in little movement of a teeth. So the patient has to wear aligners almost all the time. We say 22 hours. Because they can take aligners to eat, brush, and floss, but otherwise you sleep with that, and during the day you're wearing this all the time. It takes getting used to it. This Invisalign usually takes a couple hours, and then you talk normally and people don't even know that you have them on. So sometimes on Invisalign, if you have to have a specific, like let's say rotation of a tooth, we will add up we call them buttons on the teeth, and they're add from a composite, so you can't even see. But if the patient calls and say, I lost my button, that's mean they chipped that part of a tooth. It's very easy to fix it. They just have to come with the Invisalign tray, and then it was, for something like that, is never charged, but you need maybe 10 minutes to 20 minutes the top for procedures like that. So Invisalign will divide on an express case and a regular case. Express case, like it says, it's quick, usually up to 10 aligners. It's a different price, different code, and a comprehensive Invisalign, different code, different price. After that, they also have to have a retainers, and retainers, they have another code, And again, clinical staff will have a treatment plan for you, and it will say Invisalign, comprehensive, and the retainers included in it. Invisalign treatment, it depends. It can take 3 months, can take the whole year. It depends how difficult it is, the severity of that. But they are great because people can really enjoy, eating, brushing, flossing. It's usually challenging when you have irregular brackets. In some cases, you cannot do with Invisalign. It has to be controlled by irregular brackets. If you're perfect and everything is good in your mouth, we have to check if you grind your teeth or not. And then if you do, then we offer a mouth guards, okay? The mouth guard is, like in a store they sell and they say mouth guard or night guard and it's flexible. That's totally wrong, because in order to have protection from grinding, it has to be hard. It cannot be soft. If you put soft as a night guard, you promote grinding because your mouth is going to try to chew more. So you're encouraging the better behavior. Mouth guard, we do usually, we call them hard soft or a comfort, because they are hard outside and they are a little bit softer material inside, so it's comfortable on your teeth. And when we do mouth guard, it's always for one arch, and the provider, the dentist, will choose if it's the upper or lower. If we have a patient who are like gagging and they don't like the whole arch, it's another mouth guard, different type, and I call this NTI, and it's a small one. A small one, it goes only from canine to canine. But the whole purpose of a mouth guard is to disclose your occlusion between upper and lower arch, because you still will be grinding, but that will protect your teeth and also will save your TMJ. Like, people, the jaw hurts and all that. If they have a mouth guard, like if I could, I would give it to everybody mouth guard, because everybody is grinding. Any adult, everybody is grinding. And they will protect your teeth and protect your TMJ. So mouth guard and NTI or a regular will have the same code and the same price. I think it's a lot of dental knowledge, and you go in steps, little by little. Ask me anytime, any help, and you can rewatch every segment as many times as you want to. Thank you very much for your attention.